Welcome back to A View from Legal Street. Help us help you get paid. It's our series of short videos on tips and tricks and real-world advice to help you streamline your business processes, bolster your revenue cycle, and maximize your profits. As always, I'm Zach Rothenberg, the chair of the litigation practice at the law firm of Nelson Hardiman in Los Angeles. We are 20 lawyers dedicated exclusively to the representation of healthcare providers and life sciences entrepreneurs. Today, we are very fortunate to have the dynamic duo of Michelle McCorkle and Lee Neagle of Certa Scientia Consulting. They provide a host of consulting services to behavioral healthcare companies focused on such things as licensing and accreditation, planning and road mapping with startups, mergers and acquisitions related consulting, quality management and performance improvement, and the like. So let's dive right in. Michelle, can we start with you, please? Can you give us a little bit of your professional background and what led you to founding Certa Scientia?
Absolutely. I have been working in healthcare compliance and quality management for a little over a decade. I started out with a small eating disorder treatment provider in Alabama and then moved into long-term care for a while, ran the compliance and quality program for a multi-state long-term care entity, and then moved back to behavioral health care. Lee and I met working at a eating disorder treatment center in Wisconsin and just really aligned in terms of our passion for helping healthcare practitioners, especially clinician-owned businesses, with compliance and quality and ensuring that those items are well integrated into operations so that your compliance and quality program is efficient and effective.
Great. And Lee, how about you? I understand your background's on the clinical side. So tell us about that and how you moved into consulting.
Yeah, I've been a clinician for 20 years now with a primary specialty in eating disorders and anxiety disorders. And I've been able to kind of run the whole clinical gamut from being like a tech staff all the way up to being a clinical director, then eventually moving into operations and overseeing multi-state eating disorder programs across the country and helping some programs with startups. And one of the things that really came up for me, and this is where Michelle and I aligned, which is there are a lot of really good clinicians in this world. And as Michelle and I got more involved with advocacy efforts, things like the Mental Health Parity Act and really wanting mental health to be seen the same way as medical health is, we started to see that there were some pretty significant gaps in terms of compliance, regulatory requirements, what can or can't be done, like how different each state is from another state depending on levels of care. And really a lot of us as clinicians that start up programs or run programs don't know what we don't know because we don't really ever get trained this. So we thought okay, is this a space that Michelle and I could help build platforms so that really good clinicians can provide really excellent care without losing sleep at night or their hair prematurely falling out because they're worried about getting sued or something's going to ruin their entire business. And there's not a lot of people doing that. So we figured it would be a good place for us to get into to help providers.
That's great. I guess it's sort of letting people work to their strengths. And
yeah,
you can fill
absolutely.
Gaps. Excellent. So I know you do a lot of work with companies preparing for licensing and accreditation surveys. Can you give us a sense of what you're seeing as the most typical, call it pitfalls or problem areas that you see that are keeping folks from having a successful outcome?
Yeah, absolutely. So one of the biggest things that we see is the Suicide Prevention National Patient Safety Goal. It's NPSG 150101. And Joint Commission, every time they come in, they have a few things that they call national patient safety goals. And those are areas that you'll always get surveyed on, no matter what, no matter who's surveying you, they're going to look into it. And in the past 5 or so years, they've made a few different updates to their suicide prevention national patient safety goal. And we see a lot of organizations struggle with meeting what are called the elements of performance for that goal. In particular, a lot of organizations don't realize that even if you're not a hospital, you have to do an environmental ligature risk assessment. And so a lot of organizations that we work with don't know what that is, have never done it. And it's something that Joint Commission really focuses on because they want to ensure that even if you're in an outpatient treatment setting or residential treatment setting, that you looked at your environment of care, you know where there are risks for suicide. And if you have somebody who's high risk and you're waiting for the ambulance to show up, or you're waiting to get them assessed by the psychiatrist, that you know where in your building you can have that person and make sure that they're safe during that transition period. Another element of performance that we see missed a lot is the discharge safety planning component. So Joint Commission updated the National Patient Safety Goal to require that if you've identified somebody who is at high risk for suicide, at the time of discharge, you should work with them to come up with a safety plan and talk through, okay, what are some of the signs that you're about to go into suicidal crisis? What are some things that you notice in yourself when you're starting to escalate that maybe we can address early on with coping skills, as opposed to you getting to that point of suicidal crisis? And so a lot of organizations don't think of that. A lot of clinicians, when they hear safety plan, still think of a safety plan as something that you do while somebody's in treatment. That we have this person, we've identified them as high risk, we have them on this safety plan while they're in a residential setting, and then we take them off it. Versus, no, this is something for the individual to use as a tool at the time of discharge. And it's particularly important to keep that in mind because any suicide of a client within 72 hours of discharge from a residential setting is a sentinel event, which has a whole nother, I mean, we could probably talk for a very long time about sentinel events and don't have time to do that today. But it's particularly important that organizations are covering themselves in those higher risk areas to make sure that they can demonstrate they've done what they need to do.
That's great. Thank you.
Yeah.
On the topic of mergers and acquisitions, I know you do a lot of that work. When you're on the buyer side in particular, and you're looking at or doing due diligence on a target acquisition, what are you looking at? What areas are most important or interesting or critical to you?
So, if you're a target to be bought or your buyers are interested in it, the first thing they're obviously going to look at is profitability of the organization. Like, does it make sense fiscally, right? But then right underneath that, there's a discussion of are there any underlying significant risks that could damage the reputation, the licensing, the ability to provide services? So that where Michelle and I tend to come in during these processes is we're going to start looking at some areas, and Michelle even talked about them. They're aligned with Joint Commission. And we use Joint Commission a lot because a lot of our programs are Joint Commission accredited or seeking Joint Commission accreditation. Suicide risk assessment, environmental care, but then we start getting into, and this is an area that we see a lot of, is what is the staff training and competency of the individuals delivering care. So that's one that's really come up over the last few years because unfortunately there's been some pretty significant incidents at larger, well-known treatment facilities, and there starts to be discussion about what is the training, how are you as an organization determining that this person is appropriate to provide the services that you said they can provide. And we see a lot of confusion about performance improvement or performance evaluation and competency assessments. Competency assessments, how do I know a therapist knows how to provide DBT skills or CBT skills or ACT skills, or can conceptualize the treatment of eating disorders or substance abuse appropriately? How is that overseen? And then especially for larger systems that have a large tech pool population, some places call them behavioral health paraprofessionals, some places call them techs. They're usually your youngest staff members who spend the most time in front of clients and have the least amount of formalized education. So what does your boundaries training, your dual relationship training look like, your observation and supervision of those individuals, because that could lead to some pretty significant outcomes if you're not doing that appropriately and you have an event like Michelle talked about, a sentinel event, which could really damage the profitability or the viability of a company. So that's one area that we really see and we focus on a lot. And the other piece is looking at charts and documentation. Is the documentation that's being done actually reflective of the care that you say to payers that you should be delivering, right? And we see that a lot, especially if places have 15, 20, 30 private insurances that they work with, do they have the payer manuals, and do they actually incorporate what those requirements are into the delivery of care? Because I think the scariest thing in our world, sometimes next to like AMA, is the word clawback. Right. And clawbacks tend to happen years down the road after an acquisition has been made, and you realize, oh, we haven't done all of the requirements. And then I think the other piece that Michelle and I talk a lot about, and I'm sure you do too, Zach, is fraud, waste, and abuse. Like that's one of like the first things we're going to hit. We look at these places. So it's those low hanging fruit that can do the most damage to the organization. And if you're the seller, it's going to really affect the value of what somebody's going to want to invest in your program. I look at it as a house. It's a beautiful looking house on the outside. It's in a wonderful neighborhood, and there's massive cracks in the foundation.
Right. And especially with things like clawbacks that you don't know, it's the analogy I thought you were going to go with was like a plumbing leak behind the wall that you don't even know about.
Right. Absolutely.
Yeah, that's a great one. Thank you for that. And I know you guys, I'm shifting gears now to your work that you do with startups. I know you do a lot of that. So if you could give one piece of advice, and this is for either of you, one piece of advice to someone who's starting out fresh with a new behavioral health business in today's climate, today's economy, what advice would you give them?
I would say that there's never been, in my experience in like the last 20 years, never been a more prime time to deliver or start programs, as long as you're, being ethical and providing good services, right? Like, let's say that, because our country's not meeting the demand of mental health services that are out there. The first thing that I would say, and Michelle can chime in on this, is know who's licensing you and know who's going to be your regulatory body, and get those requirements and start from there. It's so much harder to work backwards after you've already done something than to just start things the right way.
And I guess that applies not just to the regulatory body, but to the payers as well.
Absolutely.
Yeah. Yeah. And I think going off of that, I would say don't take shortcuts. So it's really tempting when you're starting up to have a lot of pressure to, we need to open up the doors tomorrow, and what the fastest way that we can get open and start getting paid. And Lee and I have unfortunately encountered some pretty terrible situations where somebody was not aware of the requirements from the beginning and didn't pull those licensing requirements, or wasn't familiar with the payer requirements. And then they find out, oh, this payer requires me to have a psychiatrist, I don't have one. Or this payer requires me to have a child and adolescent psychologist, I don't have one. Or even worse, a lot of times, I can't use this building that I thought it was going to use because it's not zoned appropriately, or it doesn't meet the necessary life safety code. So don't take shortcuts. Do your research on the front end. Work with people that are experts in the field or in the areas that maybe you're not as strong in, and make sure that you have a good roadmap to open up so that you're not surprised on the back end.
That's a great one. I can't tell you how many times we've dealt with clawbacks where the time period that the payer is looking at is the first 3 months of operations. And the provider says, well, yeah, we were just getting started. We didn't really have our legs under us, but now we've got a much better system going, a much more compliant program. Too bad. You were still open, doing things in a non-compliant way for those first 3 months. The fact that you were just getting started is really no excuse. But that's great. Appreciate that.
And I think, just real quick, one of the areas that Michelle and I talk about all the time in our experience, and we've worked with programs across the country, is if you have a question, I have yet to run into a licensing body or board that has a surveyor of the day that wouldn't be helpful. Go ahead and give them a call. Sometimes there's this kind of feeling of if I call them and tell them I'm calling from ABC's treatment facility and I have a question about this, all of a sudden they tack us on their radar and go, these people don't know what they're talking about. So then we have people that are interpreting regulations and guidelines without directly asking the industry that has created them. And then they get themselves in trouble further down the line because, like you said, they've been doing it wrong for 3 months because their interpretation wasn't accurate.
Right. And for what it's worth, we often call anonymously. So that's an option as well. Yeah. You don't have to say who you are. Last question here. When it comes to quality management and cost savings, I know you guys emphasize this concept of value stream mapping. So what is that, and how does it fit into sort of the big picture of consulting with behavioral health businesses?
Yeah, absolutely. So value stream mapping is a tool that allows you to visualize, analyze, and improve all of the steps in a process. So essentially what you do is you identify a process that's problematic. Maybe it takes too much time. Maybe you find you're looking at your admissions process and you discover that half of the documentation just doesn't ever make it into the record. And value stream mapping is a tool you can use to break down every single step in a process, look at how long each step will take, where that step is occurring, and then have a discussion about how to improve the efficiency and quality of that process. And it accomplishes a few things. One is it's a way to improve the efficiency of your process. And so you often see a lot of cost savings because you've improved, how fast you can get somebody from the waiting room back to see the provider. And so people aren't walking out because they're sick of waiting. It improves the compliance of the process and adherence to quality expectations. Nobody wants to, we've all been to doctor's offices where we've had to wait forever, right? Nobody wants that. So it's bad for the customer. Usually when that type of situation is happening, there's documentation that's not getting done or other compliance issues that are happening. There are a whole lot of buckets that value stream mapping hits to make sure that you're providing good care, compliant care, and efficient care.
Fantastic. Michelle and Lee, this was great. Thank you for taking the time. It was really a pleasure speaking with you.
Yeah, thank you so much, Zach.
Yeah, you guys take care.